Okay, well, I think we'll get started gently because there's people still coming in. Welcome to this webinar. It's organised by the Policy Research Unit in Healthy Ageing, funded by the National Institute for Health and Care Research. And in HAPRU, as we call it, we have a series of webinars. And towards the end of this one, I'll tell you about what's happening in the next webinar in May. But this one is focusing on inequalities in later life. We have two presenters. Matthew Prina and Abidamrin, who's going to be presenting second, Amino. So we will record the webinar. So we're recording already, and then we'll post the webinar onto the YouTube channel that HAPRU has. And we'll also send you the link afterwards so you can access it if you want to go back and check anything that you hear. As I say, we have two presentations. We hope to have a third one from Magdalena Valbaum, who's one of my colleagues at LSE, but she is on leave and has discovered that where she's on leave in a remote farmhouse in Cornwall, there is no Wi-Fi, so she's not presenting, so we'll arrange for her to present in a future webinar. So just as we go through, we're going to have the presentations, have both of those first of all, and then we'll have time for question and answers afterwards. If you've got questions you want to ask or comments you want to make, could you put them into the Q&A function? If you look at the top of the screen, you'll see, on my screen at least, going from the left, you've got chat, then Q&A, then people, and so on. If you can use the Q&A function, if it's there, to put your comments or questions, please do. Some systems don't seem to have that. So if you don't have that, but you have got the chat, you can use the chat function. And then Linda Welch, who's managing today's webinar, she will be keeping a watch on both of those, and then we'll pull questions out of those for you either to ask in person, or I can read them out if you prefer me to when we get to the end of the presentations. So I think I'm going to hand over now to Matthew. Matthew, I'm going to let you do your introduction to yourself, and please do put your slides onto share mode.
Do that in a minute.
We can see them, but that's perfect. Yes, perfect. Thank you.
Perfect. Great. So hello, everyone. Well, thank you so much for being here today. I'm Matthew Prina. I'm Professor of Aging and Epidemiology at Newcastle University. And today I'm going to talk about a project that we've been developing as part of our Policy Research Unit in Dementia and Neurodegeneration that is led by Exeter University. And as you can see here, it has been quite a team effort, but I really want to acknowledge all the work that Laura Gamble and Yutsubu have been putting in analyzing this data. It's quite a lot of complicated analysis, so all the kudos go to them. So at Dementia, kind of the project that I'm really going to talk about was really focusing on understanding healthcare utilization after the diagnosis of dementia and whether there are inequalities in access. And a dementia diagnosis is often described as a moment that changes everything. But when it comes to support, it's often unclear what actually follows. So we know from both families and also professionals that care after diagnosis can be fragmented, reactive, and really heavily reliant on kind of crisis response, especially hospital admissions. At the same time, we have NHS policy, which is very clear about where we want to go in terms of direction, with the long-term direction towards prevention rather than crisis management, community and neighbourhood care rather than hospital-led care, and also better coordination through integrated care systems. But I suppose in order to redesign services in such a way, we really need to understand a bit more about kind of very basic questions, such as what actually happens to people after they're diagnosed with dementia, who uses GP services, who ends up in hospital, and whether those patterns do change depending on where people live and on who they are. So in this work, what we did was really analyzing national health data from a data set called CPRD, so Clinical Practice Research Data Link. Some of you might be familiar with it. And this included about 33,000 people, or over 33,000 people diagnosed with dementia or newly diagnosed with dementia between 2021 and 2022. And what we did was to follow each person for a full year after diagnosis, and looked at the primary care records and also at the hospital records. And to kind of contextualize these findings, we really compared also people with dementia to similar adults, so people who kind of had the same age, were the same sex, and lived in the same region, but who did not have dementia. And I think this gives us one of the, I suppose, clearest pictures so far on demand on services after diagnosis of dementia and how evenly or unevenly care is distributed. What we also did in order to validate our findings, quantitative findings, we conducted targeted consultations with people living with dementia and their carers. And we've also been conducting a review, an umbrella review, so a review of existing systematic reviews, exploring inequalities in healthcare utilization for people living with dementia. I'm going to primarily be focusing on the statistical analysis, but I've got a couple of slides on both the consultations and also on the systematic review. So in terms of what we found, I suppose the first headline finding is simple but important. So people with dementia use substantially more healthcare than comparable adults who don't have dementia. So in the first year of diagnosis, if you kind of look at this figure here, they've nearly doubled the number of GP and community care contacts compared to people without dementia. But those patterns are quite uneven. So if you look at in terms of kind of clear differences. So for example, people of Asian and Black ethnic backgrounds tend to have more GP contacts than white groups. And also we found that there were strong regional differences. So the Northeast and the Northwest had lower utilization. People living in Northeast and Northwest had lower healthcare utilization, GP utilization, compared to people living in the Southeast, and people in London and Southwest had higher GP contacts. And those differences remain even when we accounted for people's underlying health needs. So we adjusted for comorbidities. And I suppose that suggests that these are not simply individual choices or medical differences. They kind of reflect more how services are organized and accessed in different parts of the country. When we start looking into hospital admissions, we found quite similar figures. So almost half of the people living with dementia were admitted into hospital at least once in the first 12 months after diagnosis. And the strongest inequalities here were linked to deprivation. So I'm sorry that this slide has a lot of different findings here, but if you look at the deprivation row, you find that people living in more deprived areas were more likely to be admitted into hospital, were more likely to have repeated admissions, so a higher number of hospitalizations in the first year, and also were more likely to spend longer periods in hospitals. And again, these patterns remain even after we adjusted for comorbidities, so having other conditions and also previous service use. So, in other words, deprivation itself was strongly associated with heavier hospital use. Region and I suppose urbanicity as well also mattered here. So, for example, hospital use was highest in London and lowest in the Southwest. Again, these are not very small differences, and they're probably not as easily explained by clinical lead alone. What we then did was to look at primary care and hospital costs. And I'm kind of going to put them up here both. And as you can see, hospital costs and also primary care costs in people living with dementia were pretty much double across both primary and hospital costs. So once again, as expected, we kind of saw similar differences in those identifying patterns of utilization. So with certain groups having higher costs than others, again reflected, I suppose, in the higher service utilization. So for example, if you look at primary care costs by ethnicity, we found that there were kind of clear differences. So people of Asian and Black ethnic groups had highest median costs among people with dementia compared to people of white ethnicity. And if you look at hospital costs, again, the deprivation trend that we saw earlier was kind of very similar. So mean costs rose from 2,859 in the least deprived areas to 3,448 in the most deprived. So the main findings that I was going to present from the statistical analysis, there's obviously a lot more data and a lot more analysis that were carried out, but in the interest of time, I'll focus on kind of some of the key highlights. When we presented our findings to stakeholders, a number of themes came up, but I'm going to give you with a couple of quotes in terms of thinking about how do we interpret those findings. And the first one is around deprivation. So the quote was, some deprived areas don't have access to GPs, so therefore people go to A&E, which I think it's a very possible explanation for some of the findings that we found. At the same time, the second one refers more to the kind of lower hospitalization rates that we found among people of Asian ethnicity. Which in my mind thought was maybe like driven by the fact that people of Asian ethnicity might be using GP services more and therefore less reliant on hospital care. But for example, one of the potential explanations also is the fact that Asian families, for example, are living in even more fear of their loved ones having to go into hospital because of language or cultural issue. So obviously, I can't tell you which one is the explanation, but the possibility for kind of some of the findings and some of the differences that we found in terms of ethnicity. In terms of the umbrella review, we're currently in the process of writing it up. We identified about 30 reviews that met the eligibility criteria. 28 focused on dementia. There was 2 on Parkinson's disease. But the majority of the reviews really focused on social demographic disadvantage, especially ethnicity. I think about 18 of them focused specifically on ethnicity. And then there was some on cultural and communication related factors, about 11 on geographic factors, some on social support, and some on health status. And you can see, obviously, those numbers don't add up to 30, but because so many reviews looked at multiple factors. And in terms of outcome, again, obviously primary care, secondary care, treatment and prescriptions, a couple on end-of-life care, which is quite interesting, and then a few on care pathways and community and social care, but there were far and few between the kind of community and social care. There weren't that many. So if there is one message that I would like you to kind of take away today, is that I suppose dementia creates a predictable need for care after diagnosis, but that the way that care is currently delivered is uneven and often, I suppose, reactive. And I think also the findings suggest that primary care is doing a huge amount of work, but maybe not always in a balanced way. Hospitals are still absorbing the consequences of gaps in community support and inequalities in deprivation, and also in terms of geography, are translating into different care experiences. The strongest inequality that we saw were around deprivation, ethnicity, and region, and those don't appear to be just purely about individual health differences. I think it's highly likely that this is likely to be driven by system level issues, how services are organized, funded, and accessed. And I hope that this work obviously will provide a national baseline and a kind of starting point. And I think it tells us where demand is, where inequalities persist, and also where change is most urgently needed. And hopefully, as we move towards more neighborhood-based models of care, this kind of evidence can help ensure that people with dementia, wherever they live, receive the timely and supportive care that they deserve. So I'm going to end it there, and thank you very much for listening.
Wonderful, Matthew. That was brilliant. Thank you so much, and really helpful. So as I said at the beginning, and if you've just joined now, if you've got any questions or comments linked to Matthew's presentation, can you put them into the Q&A function? You should see at the top of the screen. If you don't see Q&A there, then you can put it into the chat function. If you don't see either of them there, then the advice I've got from Linda is you log out and rejoin, because you should be able to join. But hopefully you can see one of those. So please do go with those. And we're going to go to Abadan now, who's going to give his presentation, and then we'll have the Q&A part of the webinar afterwards. So well done, Abadan, you've anticipated what I needed, so please do go ahead.
Martin, and thanks everyone for joining the presentation today. My name is Abadrin Aminu. I'm a research associate in the NIHR HAPRU. Today I'll be discussing digital GP appointments and health inequality. And I think I'll be linking this with a large-scale evidence work which we've done, which is the accessing inequalities in digitalization of GP consultation associated with pandemic using the Open Safely platform. This work was published last December in the BMC Medicine Journal. And I'm going to be linking this work to the ambition to move from analog to digital healthcare in the NHS 10 years plan. So just a bit of a context to this, the NHS long-term plan sets out major shift from traditional or analog systems to digital first primary care. The goal is to improve speed of access, efficiency, and patient's convenience. In simple terms, we could say that the NHS is aiming for digital to become the default way for patients' access care. And a bit of background. This study was done to analyze the impact of the COVID pandemic, which was a major driver for the transition from face-to-face to digital GP consultations. The face-to-face consultation was rapidly reduced during the pandemic, as we could all imagine, and the GP services adopted remote methods at scale. It includes online triage, app-based booking, and remote consultations via phone or video. This created a natural experiment where digital care was implemented quickly across the entire system. And our study looked at analyzing these differences by by analyzing data from approximately 19 million GP records from the said platform, the Open Safely platform, covering the period between 2019 to 2022. The research examines trends in remote consultations and, importantly, how this varies across different population groups. So, the key question for us is not just whether digital care increased, but we were interested in who is actually benefiting from this. So, so that's one of the major goal for this particular study using the Open Safety platform. And we did use different statistical modeling to analyze the trends and the disparities in the use of the remote consultation. For the key variables, this study focused on 4 key demographic variables: the age, socioeconomic deprivation, using the index of multiple deprivation, ethnicity, and sex. These are important because they are kind of strongly associated with health inequality. So we thought that, this should be the key variables for analyzing the inequality that we were interested in. And for the findings, one of the most striking findings for us is the rapid expansion of remote consultations during the pandemic. They effectively tripled, as you can see from the table, that pre-pandemic. So we had 3 different years. There was a 1 year pre-pandemic, which was kind of the anniversary of the day that the national lockdown was came into effect, which was in March 2020. So a 1 year preceding that was the pre-pandemic year, and then we have 2 pandemic years, effectively in 2020 to 2021 and 2021 to 2022. And we could see that the remote consultation kind of tripled from effectively from March 2020 to about 32 million from the 10 million in the preceding year. And that got slightly maintained, although it became a bit reduced in 2022. They effectively tripled, like I mentioned, And importantly, consultation patterns did not return to the pre-pandemic level in the period that we have analyzed, which suggested a kind of a structural shift in the use of remote consultation. And this supports the NHS view that large-scale digital transformation is both feasible and sustainable. And this is another kind of view to that particular numbers and on raw counts of the consultations that was done monthly using remote consultation by age. And we can see that individuals in the age 18 to 49 seem to have had the highest use of remote consultation. Although strikingly for us is pre-pandemic, we saw that the individuals age 85 plus actually also used remote consultation in the proportion to face-to-face consultation. We saw that they actually were not doing badly, but obviously in the pandemic years, individuals in the age 18 to 49 seems to be those who have benefited more from the use of remote consultation. And in the further analysis that we have done to look at the probabilities of remote consultation by the different demographic variables that we have looked at, we saw that uptake of digital consultation was not equal across the population, obviously, and the lower usage was seen among older adults, people living in more deprived areas, and some ethnic minority groups. In contrast, the younger and more affluent population, as you would see from the graph here, the most deprived are those in the group 1 of the IMD score quintile, rather, and then those who are the least deprived are in the IMD 5 quintile. And we could see that those who are more affluent population were more likely to use remote care. This shows that digital care can actually, in a way, reflect and reproduce existing social inequalities that existed before the pandemic. Because before the pandemic, the most affluent group, which was the 5th deprivation quintile, like I mentioned, had the lowest probability of having consultation being held remotely. And afterwards, they seem to have had a more usage of remote consultation, and the white ethnic group most specifically had the highest probability of remote consultation across the study period. And the interpretation for this is, although we didn't look at how different technologies over the pandemic had contributed to this, our analysis has shown that increased use of remote consultation and total appointments have changed during the pandemic, and digital appointments may present a technological barrier to some, and these inequalities could have been driven by multiple factors, including digital access linked to digital literacy, because digital access is not just about having internet, it's about digital literacy, confidence in using technologies, and trust in healthcare systems. We also think that this might have been linked to language barriers and cultural differences. This is because digital transformation is it's not purely a technical issue. And it could have likely been a broader social challenge, as we've seen from the findings in this particular study. As a form of evaluation, we feel that this study has shown clear strengths in the area of having access to large data sets and real-world evidence that are relevant to clinical practice. However, there are some limitations, such as reliance on routinely collected data, which has its own inherent challenges and potential differences in how consultations are recorded. Overall, the key insight in that is that the digital healthcare is not inherently equitable. It depends on how it is implemented. And as a conclusion, we feel that the digitalization of primary care, in line with the NHS digital shift, has shown to increase overall GP appointment, which is a good thing. But without deliberate inclusion strategy, it risks deepening health inequalities. And that is the reference to the peer-reviewed publication for reference and further reading if anybody is interested in that. And thank you for listening. I'm happy to take questions, and you can, also reach out to me if you have any feedback. Thank you.
That was great, and both speakers have been brilliant in terms of timekeeping, so thank you so much. All right, maybe we can stop sharing now and then we can see each other on the screen. So that's great. Okay, so as I said earlier, if you have any questions, let me just put them into the Q&A or comments, of course. Please do put them into the Q&A function. And there's a couple there, and any from the chat. If you can't use the Q&A, please do use the chat. And then given the number of us attending today, I guess we can go with verbal questions later on if we want to. So let me just go to the Q&A. So there's a question from Naomi Davies. I'm happy. Do you want to voice your question yourself? Do you want to just unmute and ask your question? If not, I'll do it for you.
Martin, I think everyone's mics are muted, so you
Okay.
just have to do it yourself. Sorry.
Oh dear, my voice will be running out. Okay, all right. So Naomi, thank you for your question. So I'll repeat it out. Wondering if the stage of dementia when diagnosis is made has been part of the study. So this is then to Matthew's presentation. Are more deprived communities receiving later diagnosis, so support needs are higher by this point? So any thoughts on that one, Matthew?
Yeah, no, I mean, I think that's a very possible interpretation. Unfortunately, we were not able, I mean, there's one of the biggest limitations of our studies that we were not able to assess the stage, the diagnosis. And so, if you think about the interpretation of the findings, when you're looking at deprivation, we know, for example, that it's very possible that people might present or might arrive at a much later stage, a more severe stage of kind of being diagnosed with dementia, and therefore the care needs are going to be potentially much higher, and that might explain why then they end up in hospital for longer periods, have more readmissions because their health needs are more severe. So I mean, I think it would have been great to be able to kind of get some kind of assessment of severity. But unfortunately, the only thing that we could look at was the kind of adjusting for a number of pre-existing conditions. But obviously, that doesn't tell us anything about how severe the dementia or the other clinical conditions are. So I think it's a kind of limitation. And to a certain extent, that answers, I think, also Chris' questions around some deprivations don't have GPs, so people go to A&E. And just to kind of confirm that there is a finding that was found also in the match sample. So it wasn't just for people living with dementia, but was across the whole population. So we found that there was a clear deprivation gradient in terms of hospital admissions across both people living with dementia and people not living with dementia. So that kind of trend and gradient was comparable. And again, the interpretation to me seems to suggest that it's likely driven to the fact that maybe people in more deprived areas might have greatest healthcare needs compared to people living in less deprived areas.
So just a quick little follow-on from that, which is, it is interesting. I mean, we're going to ask a question of both the speakers in a moment about the data sets. But we know from other research that people with dementia from ethnic minority groups do seem to have later diagnosis. I mean, on average, have a later diagnosis of their dementia. So there is a challenge. I mean, I just wonder, so a question for each of the two speakers, just jump in for the moment, because it picks up on things that are in the chat, in the Q&A. So Matthew, first of all, can you just very quickly say what you were able, what characteristics of people are available in the CPRD data sets that you can adjust for? And Abhidhamma will ask the same question for you afterwards. So Matthew first, just quickly to explain so people know about the data.
Yeah, so it's quite limited in terms of what characteristics we can adjust for. So obviously we've got urbanicity levels, IMD at a postcode level or at an area level. So that's the deprivation level, so where people live. We can adjust for what we did. We adjusted for pre-existing health conditions. So that was based on the Charlson index of 40 conditions. So again, there might be other conditions that are not part of the Charlson index that we didn't adjust for. So obviously could be a residual confound in there. we were also able to adjust for prior use of hospital services or services, so to kind of highlight people that might be already high users. And I think that was about it. I don't think we adjusted for anything else. In terms of other variables, obviously, that's one of the kind of key limitations of using CPRD, because you're relying on healthcare, kind of healthcare data. So you're not going to be able to adjust for kind of all the variables that you might want to adjust in a cohort studies. Am I on mute? I can't hear you.
I can't hear you as well. Sorry, Martin.
Martin, are you on mute? No.
Yeah.
Oh,
I
dear.
suppose maybe I'll take on the question, because I know Martin has already mentioned
Yes.
about
Thanks,
asking the same question to myself. Yeah, so we have used, maybe I'll just give a little more information about the Open Safely platform that we had used, which is a secure research environment that provides platform for accessing electronic health records. It was a collaboration between Bennett Institute for Applied Data Science in Oxford University and electronic record groups, including the TPP and EMIS. So we had analyzed data from individuals who were aged 18 years and over, corresponding to about estimated 19 million records in the TPP practice only. So yeah, that's one limitation that kind of we have sort of mentioned earlier on, that I mean, our data is from practices that have used the System 1 data for collecting electronic health records. So it shouldn't vary, because there are some other papers that have been published on this and talked about the national representativeness of the data. But yeah, we should mention that that's the case, that we have used the TPP data in Open Safely. And as regards to what we have, I mean, the type of variables that we have kind of adjusted for, mentioned in the data, in the presentation rather, that we adjusted for age, gender, and deprivation level and ethnicity. And you would agree that this is a very large scale analysis, and the operationalization of Open Safely means that we are not able to interact directly with the data, so we are only putting in some codes. So it becomes really kind of technically difficult to adjust for multiple variables beyond what we have done, because it makes the analysis a bit more complex to run through their platform. But what we have found is really interesting, and we feel that could be a form of a background for discussing further the inequalities that may arise from the shift towards digitalization of primary care, GP appointments. And yes, that's a bit of a background to that.
Okay, thank you. Can you hear me now?
Yeah, we can.
Okay, I don't know what's happening on my computer. So thank you, that's really helpful. I mean, it was really useful, because I think the beauty of both these data sets is they cover large numbers of people, very large samples, which gives us a really good opportunity to look at these patterns that you've been looking at. And I wasn't asking you to apologize for the limitation of your data sets. I think these are great data sets, but different data sets allow different things to be done. So there's a question from Barbara Hamrati. Can you clarify what proportion of the remote consultations, Abadamrin, were video, and what proportion were telephone based? The required level of digital literacy for phone consultations is likely to be much lower.
Yeah, thanks for that question, Barbara. Although, like I mentioned in the presentation, that we didn't really kind of go a bit further than we had expected to look at the different technologies. But one thing that was significant, though, because we had opportunity of seeing the NHS annual GP appointments publication, and we were able to compare our data with that, is that majority of the digital consultation were actually telephone consultations, which was more of about 8, which is, I think, if I'm not mistaken, it's about 80% of the remote consultation data that we had. So yeah, that's more kind of towards what you have mentioned. It was more of a telephone consultation for the remote consultation.
Okay, thank you very much for that. I've got a question for Matthew from Deborah Price. So she says, thanks, really interesting. I can imagine that one of the drivers of increased hospital costs may be about coordination with social care support that might be needed to facilitate hospital discharge. Are you able to say from your data whether this is a factor in driving differentials in costs?
Unfortunately not. I would love to. I think it will require quite a complex analysis. I'm not entirely sure how accurate the data will be in terms of that coordination with social care support, find some codes that might have kind of discharge. But I think it'll be very hard, I think, to have a kind of clear differentiation between these and just kind of I mean, to kind of distinguish delay in discharge based on this or delay in discharge because of other factors. I think I can't. I mean, Martin, actually, can you think that the data will be able to tell us that? I think it would be quite hard, wouldn't it? I can't think of a potential way of doing it. Unfortunately, it would be great. It's a great question though, and I think it's very much a possibility, but I don't think our data will be able to tell us.
No, I think it would need, I mean, because we know that, you know, health routine, regularly collected health services data and social care data don't very often coincide, don't really get brought together. It might need, you know, with some of the cohort studies like Ideal or Determined and some of those which have collected both health service data and social care data, and also unpaid carer, so family and other unpaid carer support. Because so in your presentation, Matthew, when you're talking about the differences in hospital use by those different, you know, characteristics of the population, you know, reduced hospital use is perhaps an indication, perhaps of a good thing. People are a bit healthier, or it might be a bad thing because it means that the burden, the impact on the family and other carers is much greater. So it's difficult to interpret without having the other data. Okay, so I mean, just a question perhaps to both of you, if I can bring this in, if I'm not quite sure I've got this entirely sorted out, but what you both showed were some really interesting differences by deprivation. And what was interesting from Aberdunrins, if I got this right, that people were less likely to use remote consultation if they were from more deprived communities or localities. And Matthew was showing primary care contacts are lower in the more deprived areas as well. So there's something about deprivation which is sort of, there's additive elements to it, but the patterns are not entirely the same across the two studies. I'm asking a very vague question, but is there anything you want to reflect on, given having seen each other's presentations, slightly different patterns in relation to particularly deprivation and indeed with ethnicity, I think, between the two studies? Any thoughts on that? Matthew? Yeah.
Yeah, okay, yeah. I mean, I think some of it could be driven by I don't know, lower health literacy maybe, or maybe even like potentially mistrust in kind of using primary care services. So maybe prior experiences of discrimination of poor quality of care, putting people off. And therefore that would explain maybe like the lower use of primary care services, but then would explain also the increase in hospital use because people avoiding, you know, people kind of wait until the last minute, until the condition is potentially too severe or too urgent to deal with it. That's a potential explanation. But yeah.
Yeah. Sorry, Martin. If I heard you correctly, I think that maybe I don't know if it was a slip of tongue or from myself, but our data actually showed that those from the least deprived had more of the face-to-face consultation rather than the remote consultation overall. And and those who were in the least deprived, group had more of a remote consultation. And our explanation to this is, kind of linked to more of, NHS staffing, because we believe that those who live in the remote, who are more of kind of least deprived, who are more in the affluent group, are more likely to have a balanced GP to population ratio compared to those who are living in the more who are more in the deprived group. So our explanation is those who are in the deprived group are more likely not to have enough GP appointments offering face-to-face, and we explain the reason why they resort to remote consultation. So that was the point I was trying to make, and forgive me if you didn't get that correctly from my presentation. Obviously, that's what our data actually showed. And yeah, I kind of support the view from Matt in terms of the fact that people who have some level of distrust with the system might also not be able to kind of access as much as others who have had the opportunity. So that's a bit of context to that, just to kind of put that straight.
Yeah, no, that's really helpful. Sorry if I misunderstood it myself. So one just quick thought, just reflecting back on this. So I know we have these new disease-modifying treatments, drugs for dementia as a possibility. They're not yet being given the go-ahead and support by NICE in England yet. But there's evidence from when the thrombolytics were introduced for stroke care, there's evidence that when they were first introduced into the UK, women were less likely to get access to them than men. And the reason for that was that women who had experienced a stroke were less likely to have somebody to take them to the clinic for the infusions than men. And there was a very clear marked differential. I suspect that's not the case anymore. I don't know, but it was certainly that was the case. So what you're both describing are these differences by different groups in the population, which could be, I mean, both of you talked about widening of inequalities, either pre and post COVID or by different characteristics. Those inequalities could widen even more with the introduction of new medications if we don't get appropriate support for people to access services when they need them. So that's, sorry, I'm just throwing it out as a comment, but Matthew, you know the dementia area well. Do you have a comment on that?
Yeah, I mean, I think you're spot on. I think it definitely can happen. And, whenever you introduce the treatment, there's always, it's really important to think about who's going to get it ultimately, and whether there's going to be different groups who are going to benefit more from it. So I think it is important to think about how any rollout is gonna be done, and what kind of support information is also given during any potential rollout. Interestingly, Martin, I mean, I didn't discuss it during my presentation, but you mentioned widening inequalities before and after COVID. We actually did repeat all the analysis pre and post COVID to see whether we found any differences, and for the most part, actually there were no. I mean, all the trends were exactly the same. In terms of magnitude, in some cases, the privation one, I think for hospital was slightly larger, but on the whole, the kind of inequality didn't seem to be widening post-COVID, which was quite interesting. But I think you're right. It could be that if we were to introduce new treatments further on, who's going to get it, and there's definitely going to be some element of inequity there and inequality. Potentially linked to health literacy, who's actually going to go to the GP to get those treatments, and who has access to those treatments. So I think you're absolutely right.
Okay, thank you. So we've still got anybody got any further questions? And can you, if so, please just type them quickly into the Q&A or the chat. Or if you've got a question you're about to type, just type "I'm about to type it," and I know to wait for you. But okay, I'm not seeing any movement there. Okay, all right. So it's therefore my wonderful pleasure to thank. I mean, we had two brilliant presentations. Thank you so much. It's always easy to chair when people keep to time and have excellent slides and interesting studies. So thank you so much. Chris has just added something into the chat to emphasize one of the things that Abidamrin presented about the deprivation. So thank you very much for clarifying that, Chris. So as I said before, the recording from today will be put onto the YouTube channel, and we'll send you a link so you know where to find it, and we'll circulate it far and wide. Abhidhamrin already talked about paper from the study, but I know that stream of work is continuing to some extent. Matthew is going to be publishing his findings from that study through the Dementia and Neurodegeneration PRU in due course. So thank you very much for that. Thanks also to Linda for organising the session, and apologies from me that my computer suddenly muted without touching it. So apologies for that. So the next webinar in the HAPRU series is on the 6th of May at 12 noon, same time as today. And the title of that is Improving How Physical Activity is Assessed in Primary Care. So please do come along if you can. Please do pass on the details to other people who you think might be interested. Thanks once again to everybody for turning up today and for your questions. And thanks to Matthew and Abhidhamrin for great presentations. And with that, I think we'll finish the webinar. Thank you.
Thank you.